Alrighty, so today's talk is going to be about tremor. So really the goal today is just to be able to talk intelligently about the three main kinds of tremor. So that would be the benign essential tremor, the Parkinsonian tremor, and the enhanced physiologic tremor. You should be fairly comfortable by the end of this talk just distinguishing which kind of tremor warrants a referral and which you can manage very comfortably on your own in the family clinic or wherever you may be as a primary care provider. So at this point you all know these objectives, so I'm not going to go over them. This is talk 3 in the series, which is also the last one. And as per usual, Dr. Bauma has been kind enough to vet all my content and also add a few things just to make sure that everything is as up to date as it should be. So we can basically jump straight in. So tremors are a very interesting problem in clinical practice, just because they can be primary tremors that generally tend to be very benign, or they can be manifestations of more systemic disease, or as I like to call it, more sinister causes that require further action than just treatment. And the problem with that is that the main tool you need in order to know where to go when you see a tremor is you need to be able to properly characterize it. So you need to be able to properly describe its behavior. The fun part of that is that this is one of those unique clinical scenarios where your diagnosis is actually very visual, and you have a very small set of very targeted physical maneuvers that you can use to provoke the tremor or relieve it. So the whole diagnostic process is actually quite visual in nature, but of course you still get the meat of what you need from your history. So of course, as per usual, the first step would be to elucidate the onset and the exacerbating or relieving factors of your tremor. So I figured I would summarize all of what you really need in a tremor history on one slide. So these are the questions that you want to ask anyone who presents to you with a tremor. So did it develop acutely? So by acutely we mean within days, or gradually, so over weeks, months, years sometimes. Is it worse with stress, illness, and or exercise? So this would be a feature of an enhanced physiologic tremor, and I'll go over that later as well. Does it improve with alcohol consumption? That's more of a feature of a benign essential tremor, so the familial type of tremor. And then of course, is it unilateral or bilateral? And if it's bilateral, did it start on one side at first? And if it's unilateral, it's always safe to ask, does it affect only the upper extremity, or is the leg involved as well? Or is it both? So generally when we talk about tremor, we talk about primary and secondary causes. I'm briefly going to talk about the secondary causes, since I think they're very important. So one thing that should always be on your differential when you see a tremor is hyperthyroidism. So overactive thyroid. This is very easy to check for. You generally just kind of look for the concordant symptoms that you would expect with hyperthyroidism. So are they sweating more? Are they losing weight? Do they have any signs of Graves, for example, so the proptosis? And it's also very easy to check a TSH, since usually patients tend to have these on file. There's something that's very frequently tested. Other causes, as with every problem in medicine, include medications. These are usually fairly acute onset tremors, and the list of medications is pretty extensive. But interestingly, there are medications that are very often used by family medicine practitioners in particular. So those include the beta agonists like salbutamol. They can cause tremors and tachycardia. Inhaled and oral steroids can do the same. There's a long list, and I also want to draw your attention to the antidepressants. So especially bupropion, which is known to, I think it's an NDRI, so known to be a bit more of an activating antidepressant. So not the best fit in someone with baseline anxiety or kind of baseline restlessness. But some of the SSRIs are also to blame there. And then of course you have the things that you would expect, like stimulants and caffeine, and then a couple weird ones like cyclosporin and imidazole. So these are mostly the secondary causes. There's a few I'll talk about towards the end. But I thought the main skill to take away from this presentation is just to be able to characterize a tremor, to talk intelligently about or use the proper words to describe it. So when you talk about primary causes of tremor, this is what we were talking about. So first of all, you would divide it into resting and action tremors. The resting tremor you can observe best with the patient's hands in their lap, so they would just kind of rest them in their lap. You can provoke this tremor with distraction maneuvers, especially if it's very subtle. So my favorite one is to close your eyes and recite the months of the year backwards. Often that will really actually exaggerate the amplitude of the tremor, which makes it easier to identify. Usually, I say usually because there are exceptions, of course, but generally when you see a resting tremor, you should be thinking Parkinson's, especially when it's unilateral. So the next step in your exam then would be to examine for the trap features. So I'll talk about that in a slide when we talk about the Parkinson's tremor. The action tremor on the right, this is the kind of tremor that usually involves with alcohol consumption. And because the action tremor, the nature of the tremor is that it's worse when you're trying to engage in some kind of purposeful movement. So it actually resembles a bit of a dysmetria sometimes. Because of that, it can often be quite disabling for people, since it prevents people from, reaching, aiming tasks where you generally need a lot of precision. And usually these people will have positive family histories as well. There are these 3 words at the bottom that you can use to further quantify an action tremor. So if you can kind of use the proper label for your tremor, it helps you narrow down your differential a little bit better. So an isometric component of a tremor means that it would emerge with sustained contraction. So for example, when they're holding something for prolonged periods of time, or when they're at the gym and holding a dumbbell. An intention tremor is that kind of tremor that we talked about. So an increase in amplitude as they reach for a target, like when they reach for their cup or when they brush their teeth. This is usually the benign and essential tremor. Just keep in mind that as people progress in their benign essential, it may start to have a resting component as well. So just because you have a resting tremor does not mean it's Parkinsonian. And then there's the postural tremor as well. There you go. So this tremor emerges when you hold a posture for a long periods of time. So like when you hold up your arms. If this is subtle, you can do what's called the paper test. So you would have your patient hold their arms out in front of them like that. You put a little piece of paper on their hand and just observe it. And sometimes it's easier to watch the paper shake than it is to see the fingers. So let's talk about some of these individually to maybe make them a bit easier to understand. So first is the benign essential tremor, is probably the most common tremor that you'll see. So this is either an intention tremor, so present when they try to reach for things, or a postural tremor, so present with sustained posture. This is usually not a resting tremor, like we discussed, unless you're very far into the disease course. So if you have a resting tremor and you want to be convinced it's benign essential, they need to have had this for like years for you to be comfortable with that. These are usually very gradual in onset. They may not present to you until they're a few months or maybe even a few years in sometimes. And usually they have other family members that are affected. Interestingly, in terms of where they're usually found in the hands in a pretty symmetric distribution. They can initially appear unilateral because they're more, they notice it more in the hand that they use frequently, so they may think it's more prominent in the dominant hand, so you need to examine it carefully. And you can also find it in the voice or in the neck. So shaky voice can be a tremor feature. With the neck one, you'd have to be a little careful. So a benign essential tremor is a yes or no head tremor. So this is a neck-centric tremor. With Parkinson's disease, it would target more the chin and the lips and the mouth. But neck is very pathognomonic for benign essential. And another last important feature is that it's basically never in the legs. So if you have a tremor in the legs, especially if it's unilateral, that is Parkinson's. And that requires further workup. So I'll show you a video of the benign essential tremor. There's a couple actually that I thought I had. I'm just going to make sure that people watching from home can see that. So this would be, that's the wrong one. So this would be an example of a benign essential tremor. So you can see he's kind of trying to eat, and whenever he tries to aim, it gets worse. You can see when he puts down his utensil, it almost goes away.
Yeah.
He's cute. Yeah, so almost goes away as soon as he puts down the utensil. There's a bit of a component left, and then it gets worse. So this is pretty characteristic of benign essential. There's a second video that I thought was also quite good, and the person actually narrates it, which is useful.
And during the resting state, there is no tremor at all. But when asked to outstretch the hand, there is a tremors and occurs in bilateral both hands. And when you ask them to write in a paper, they have difficulty in writing in a paper, and handwriting are so bad.
So we'll talk about the writing in a couple of slides from now, because those are actually things I'd like to spend a few minutes on. But basically, this is the benign essential tremor. I'll just put that back into presentation mode. There. Now for treatment. This BET treatment is what I'm going to spend the most time on, just because family doctors are going to be doing this the most. We don't, as neurologists, don't really see them all that much. So the first line would be a beta blocker, and the most effective one for tremor is propranolol. So I've seen some people started on metoprolol for benign essential tremors, but they're not nearly as effective and actually have more cardio-selective properties. So the rule here is you would start very slow and very low. So start at 10 milligrams PO/BID, and if needed, you can go up 10 milligrams at a time if needed. The goal here, as with any medication, is to use the lowest possible dose to control the patient's symptoms. If they can't take propranolol, the next second line agents would be other beta blockers, so specifically atenolol and nadolol. As with beta blockers, just keep in mind that you should be cautious of using these in patients with asthma or hypotension or bradycardia, just because beta blockers will have those effects as well. And once again, pointing out that asthma is a really important entity to be aware of in tremor treatment, because not just because it may require you to choose a different medication, but also because they may be on medications that may be to blame for their tremor in the first place. So like the Ventolin, the steroids, etc. The third line is actually barbiturate, primidone. This also helps with sleep, so you can be very effective in your medication choice if they also have sleep problems. Just be aware that of the sedating effects of primidone, of the dangers of operating large vehicles, and these are also not ideal in elderly patients. And a fourth line, if you get down that far, would be topiramate. Of course, the limitation here is that this is not a good one to use in women of childbearing age, because it is quite chargogenic. So that's benign essential tremor. The next one I want to talk about is the Parkinson's tremor. And this is actually quite commonly confused with a benign essential tremor, and I've seen either labeled for the other. So the main distinguishing feature is that instead of a postural or intention tremor, this is a resting tremor. And this is usually very gradual in onset and history. It is usually unilateral, but there are atypical Parkinsonisms that you don't need to worry about where it can be bilateral, so just keep that in your mind that you can have a bilateral resting tremor. If you're at all suspicious that your patient might have Parkinson's, you should examine for the cardinal features of Parkinsonism, which are the trap features. So this would include a tremor. This is often pill rolling tremor, resting, slow and unilateral tremor. The R is for rigidity, so you would examine them for cogwheeling at the wrist. You would check if they've ever had frozen shoulder, if they have any kind of lack of movement at the shoulder. A is akinesia or bradykinesia, so any slowing of movement anywhere, basically. So this could be reduced mobility. It could be the shuffling or festinating gait where they're very slow to get started, but once they start, they kind of speed up. Slow speech and reduced blink rate are common as well, and then you have that hypomimia feature, so the complete lack or somewhat or almost complete lack of facial expression. and the almost staring appearance because of the reduced blink rate, the mask-like facies of Parkinson's. And the P is the postural instability. So ask about falls, ask about any symptoms of orthostatic hypotension, since Parkinson's patients can get pretty dysautonomic throughout their disease as well. And just to reiterate, a unilateral leg tremor is Parkinson's until proven otherwise. Benign essential tremor does not affect the legs. If you think that your patient might have Parkinson's, you kind of have a few pieces of the history, but you're not entirely sure and think that they might be very early on in their disease course, there are some symptoms that you can ask about that tend to be a lot more subtle, but that tend to predate the physical manifestations of Parkinson's by sometimes decades. So one you may have learned about is a loss of sense of smell that can appear sometimes 10 or 20 years before the onset of a tremor. But the others are constipation and mood disturbance, so more non-specific symptoms. The one that I love using is REM sleep behavior disorder. So for those of you who may not remember, so this is the tendency to have really vivid dreams and to act out your dreams. This is where it's really useful if they bring a bed partner that can give collateral. So you can ask, do they ever get really violent at night or have really strong nightmares? Or you can ask your patient if they sometimes just tend to act out their dreams or wake up in the process of doing something. So asking all that together will be very highly sensitive and will allow you to pick up very early Parkinson's and get them into treatment quicker. So of course I have videos for this as well. This one has somewhat cheesy music at the end, but I think it's very...
of agonist and antagonist. In the following video, you are about to see a patient with Parkinson's disease with tremor in his both upper extremities. The tremor in Parkinsonism is characteristically present at rest and ameliorated during initiation of purposeful movements. Here we see the tremors of both hands ameliorated during purposeful movement and recurrence of tremor after the hand rests on the knee. This is the classic rest tremor of Parkinson's disease.
So cheesy music, but pretty striking. So as soon as they go back to rest, they start shaking again. So this does not happen in a benign essential tremor. Also, you can notice that this patient is pretty symmetric. So this is either a patient late in their disease where it's switched to the other side, or this may actually be, an atypical Parkinsonism. Usually you'd see this more in a unilateral fashion. And I wanted to just show you the video of a pill rolling tremor since it's so classic for Parkinson's. So very characteristic, that thumb against the index finger movement. So just a quick look of that. So one thing I always urge you to check if you think that you found a tremor that is very clearly Parkinsonian, just before you send your neurology referral, make sure that it's not drug-induced. So as you know, many drugs have been shown to have Parkinsonism as their side effects. So these are generally drugs that are dopaminergically active. And it's just good to identify that before you send your referral, because you can very easily fix this on your own. And you can also spare your patient just a very long wait list with pretty bothersome symptoms sometimes. So the most common culprits here are the neuroleptics, especially the atypicals like haloperidol. But even some of the atypicals have been shown to cause it. So clozapine, quetiapine, olanzapine, risperidone, all those. Just make sure that your patient didn't recently either start them or increase their dose, because either one can cause it. And then there's GI motility drugs. So metoclopramide and domperidone both have activity at dopamine receptors as well. So these are some of the lesser known agents that can give you Parkinsonism, especially in a hospital setting. So at this point, I think I'd weave in a bit of a clinical pearl. So if it happens to you that you have a patient who develops a sudden, severe, completely out of proportion Parkinsonian response after they are given an antipsychotic, you need to assess them for Lewy body dementia. So when people have Parkinsonian side effects, you usually don't expect them to be that severe, but if they're just are horrendously out of proportion with the dose or time frame, you need to consider this. And this is because Lewy body disease is a pretty interesting entity, and about 50% of patients actually have a very extreme sensitivity to neuroleptics. And sometimes, if you let it go on long enough, these can be actually irreversible. So a few quick features to check if you suspect someone may have LBD would be visual hallucinations. So the most common ones would be small animals, but actually small people are very pathognomonic for Lewy body dementia. They actually have a name. I think they're called Lilliputian hallucinations. So if you ask your patient and they tell you they see small people and they're Parkinsonian, they have Lewy body dementia. The other cognitive feature of Lewy body is that their cognitive deficits are pretty fluctuating. So sometimes that can actually be mistaken for a delirium. So just a good one to be aware of. As for treatments, if you're pretty sure that your patient has no drug-related cause for their Parkinsonism, it's pretty safe to refer them to neurology. And no one, hello.
Hello.
Hey, have a seat. Thanks for coming.
Sorry, I'm late.
It's all good. We're talking about Parkinson's.
Okay, go ahead.
So if you're pretty sure that your patient has Parkinson's, it is completely okay to refer them to neurology, as long as you've ruled out a drug-induced cause. We would never expect anyone in a primary care setting to be able to handle the treatment of Parkinson's, because it does get pretty complicated, especially with dosing. Just so you know what you can expect your patient to come back on. So standard of care is usually Sinemet, so it's a combination of levodopa, carbidopa. It works best on the negative symptoms of PD. It's not really, I think that's usually more commonly used when referring to symptoms of schizophrenia, but I like categorizing it that way. So think of all the symptoms that usually are decreased or go down. So the rigidity or lack of movement, the decreased mobility, and some of the cognitive slowing are most responsive to Sinemet. Unfortunately, the tremor tends not to be. If patients are younger, you may see some neurologists start with an MAO-B inhibitor. So examples of that would be rasagiline or selegiline before initiating Sinemet. The reason it's not very frequently done anymore is, as some of you may know, they have horrible dietary restrictions that you need to obey. So you can't eat aged cheeses, you can't go on certain medications that are serotonergically active, because you can get serotonin syndrome, and they're just very annoying in general. So usually you'll see Sinemet. And as the disease progresses, you may see the neurologist initiate other treatments, like amantadine is to get rid of dyskinesia as the medication wears off, and entacapone just prolongs the action of Sinemet. Because benign essential and Parkinson's disease are still fairly commonly confused, I wanted to give you a couple of clinical maneuvers you can make your patient do that are kind of fun to distinguish. So one is to get them to draw an Archimedean spiral. So you can see on the left, the normal one, this would be the one that you draw, should have relatively smooth lines if you don't have any kind of tremor, and the lines should be pretty equidistant from each other. Whereas in a benign essential tremor, as you remember that this is an action tremor, so worst when you try to do something, you will have these really coarse fluctuations in a much larger spiral than the one that you drew. In a Parkinson's spiral, this one should be very small. It should be relatively smooth, since you remember that a Parkinson's tremor is a resting tremor, so when you're doing something, it should actually get better. So this is one maneuver. The other one is to just get them to write a sentence. So in benign essential tremor, usually what they write is illegible. You cannot discern the letters, and they also tend to not obey the lines, because it's very difficult for them to aim. In Parkinson's disease, really the only finding is that the letters are small, but you should be able to read them, and they should be able to obey the lines.
I have a question about the spiral. Yeah. Is it important that they don't touch the paper with like they're not resting their hand?
It is. That's actually a really good point. So yeah, when you try to do the Archimedean spiral, try not to get their forearm, their elbow to touch the paper, since that may give them since that may actually cause the arm to rest more.
It's like stability.
Exactly. Yeah, you want it to be a true action assessment of how your hand behaves when you're in the middle of an action. Exactly. So lastly, we talked about benign essential, talked about Parkinson's, so I want to talk briefly about the enhanced physiologic tremor. So the premise behind an enhanced physiologic tremor is that the majority of us have some degree of tremor at baseline. So if you were to stretch your hands out in front of you, you would have some degree of high frequency, very, very low amplitude tremor that would really not interfere with your daily life. And the idea here is that some people are just very sensitive to things that may exacerbate this tremor when they're under stress. So examples of that is physiologic stress, so exercise, illness, anxiety. So a lot of people get the handshakes when they have to speak publicly, and caffeine is another obvious one. So this is one of the ones that is very easy to treat. So if your patient has a tremor that emerges really only and reliably during these times, whatever their trigger may be, you don't need to test anything further. And your treatment approach here would be trigger avoidance as much as you can. So especially advise them about caffeine, about not using stimulants if they can, and do a medication review to make sure they're not on anything more stimulating than they need to be. If this trigger avoidance does not work, you can try propranolol here as well, as you would in benign essential, just to kind of get them symptomatically a little better. But ideally, the trigger avoidance and reduced caffeine intake should do the trick. Quick talk about the acute onset tremor, since this is one of the more sinister things that you need to be aware of. So this really doesn't happen very often. So when you see a tremor that really started very acutely and built within days, you need to be very careful about how to investigate. As with any kind of acute onset thing, medications here can be to blame again. So the same list that we talked about earlier is still very much on your differential. But here, you should also consider things like environmental exposures. So consider the following toxins. So heavy metals like manganese and mercury can be culprits. Keep in mind your chemists and your chemical engineers that work in labs and that use solvents like toluene and methanol. Also with methanol, keep in mind the people who may be trying to make their own alcohol at home. And with insecticides, keep in mind your farmers and your hobby gardeners. The nice thing about these toxins is that usually these have many other features aside from the tremor. So especially with the toluene and the methanol, I think in both of those cases you would have some kind of anion gap metabolic acidosis. You would have something else, some confusion or visual change that would hint to you that this is a more systemic process. If your history does not explain the tremor, you would be totally justified in ordering either an MRI brain with contrast or an enhanced CT, depending on what you have available, to check for tumors and abscesses. Since those can also give you something relatively acute in onset. If all of these things that we've talked about so far still don't quite fit the picture and you're still confused, there are a couple of rare causes of tremor, and I will end my talk with those two. So these are really things that you may never see in your career, but for those who like zebras, I always like to talk about them. So one is Wilson's disease, very rare. So this is a disease where your body cannot properly store copper, which leads to deposition of copper in three main areas of your body. So one is your liver, leading to cirrhosis. One is the basal ganglia, which will give you these Parkinsonian tremor-like features. And the third place is in your cornea. So this is where you get these beautiful Kaiser-Fleischer rings. Keep in mind, these are very difficult to see in people with dark irises. But if you're lucky and your patient has blue irises, they're nicely easy to see, especially under a slit lamp. So since we're talking about tremors, this tremor can really take all forms. It can be resting, action, postural, and it can be rubral. So rubral, I'll show you a video of this. It's really almost striking, is a wing beating tremor. So you actually need to put your patient's arms into this chicken wing position and you will see this interesting wing beating tremor that I'll show you. That is specific for this. Tremor is usually more subacute to gradual in onset, and also make sure to ask about any personal or family history of cirrhosis or liver-related deaths. And then, of course, examine for your Kaiser-Fleischer rings. For a workup, it would be a good idea to send LFTs. The two tests that are more specific for Wilson's would be your serum ceruloplasmin and your 24-hour urinary copper excretion. And if you have a really high suspicion that this is what's in front of you, you can start zinc, which is a copper chelating agent. But it's very likely that they will need more aggressive treatment. So this is one of those cases where you actually would not refer to neurology. You would refer to internal medicine and get them involved. So I'll show you this wing beating tremor. Well, that's great. But yeah, so it's lagging a bit. So that was just showing that this was more of a postural tremor. It goes away and is not really provocable with any other kind of posture. It's literally just there. So this person is Wilson's. They go on to try to show his Kaiser-Fleischer rings, but I find them just really impossible to see. Like they almost look brighter, but I find that just really hard to make out. So that is a wing beating tremor in Wilson's. I have to keep going back here. So, last rare cause of tremor is something called affectus. I don't even know how to pronounce it, but affectus stands for Fragile X-associated tremor ataxia syndrome. So this is one of those very rare inherited neurodegenerative processes that almost always occur as an adult. Usually this happens in men over 50. It very, very rarely affects women. Like these are like case report numbers. And if they happen, they're less severe in women. Usually this is an intention or resting tremor that is accompanied by ataxia, short-term memory problems, and sometimes neuropathies as well. The diagnosis here, which is why I wanted to talk about it, is more genetic. So you can decide to refer to neurology, but I would simultaneously refer to genetics, since that's kind of the only way to confirm this diagnosis. There was a video, but really all it showed was ataxia. So just to remember what ataxia looks like is a very wide-based gait, inability to do a tandem walk, and truncal swaying. So you're kind of trying to balance your lower body with your upper body. So that's just, keep that in mind, that would be a part of your clinical picture along with a tremor. So in summary, what have we talked about today? So if you have a postural or intention tremor that is bilateral, gradual in onset, and affects the upper extremities symmetrically, then that is a benign essential tremor. You should confirm your diagnosis by asking about affected family members and whether alcohol helps the tremor. If you have a resting tremor that is unilateral and gradual onset, that's usually Parkinson's. Confirm your suspicion by examining for trap features, and rule out the drug-induced mechanism before sending to neurology. And always, of course, beware of Lewy body dementia features. So be careful in giving antipsychotics to anyone who's presenting Parkinsonian to you until you've ruled that out. A postural tremor that is low at baseline but has very clear triggers. That's usually an enhanced physiologic tremor that you don't need to do much about aside from trigger avoidance. You can use propranolol if you like, or if the patient requires it. And then there's the sudden onset tremor. So usually this is medication or toxin induced, or can be more sinister, so tumors or CNS infections, so abscesses. And once again, if nothing really fits, consider rare causes of tremor. So we talked about Wilson's and we talked about this FXDIS syndrome. And remember that this is usually in men over 50. So today's talk was a little bit shorter, but once again I made you the one-pager, so since I kind of know who's attending today, I think I'll just send them to you, so don't worry about emailing me. And this was the last talk of the series. So since I guess after this, in July, I will be teaching medical students as a resident, so please let me know if there's anything that I can do to be a more effective teacher and to just make sure that that goes smoothly. So also any questions, if you have them?
With regards to like benign versus sinister, why are tumors associated with like acute onset? What if it's like a slow growing tumor? Can you get gradual?
Yeah, it's basically, you can get a gradual tremor with a tumor for sure. It's sometimes, and of course, I mean, imagine you can also get tremors from a bleed, which would be a little less common. The thing with sudden onset tremors is that generally you just need to keep in mind that tumor can be a cause of it. So usually gradual onset tremors have more common causes like these ones, which is definitely not to say that a tumor isn't one. So if you find that it doesn't fit and even like the rare causes of tremor don't fit, then I would still image for sure in a gradual onset tremor. It's just that the sudden onset tremor should always raise alarm bells, especially after you've cleared medications as a cause. Yeah. Sweet. So I'll send the one-pager along to you all. Thank you for coming today.
Thanks for teaching.
Yes.